Okay, and Kathy, hopefully you're still there, and we are talking about your question about insulin prediabetes. Prediabetes is really insulin resistance, and it is kind of a term that develops because it can either mean one of two things. The end result is rising average blood sugar, but the prediabetes or insulin resistance means that one or two things are happening. Is that your body is basically making a lot of insulin and it's not being very effective, and therefore your blood sugars are rising. Or in your case, based on your brief description of watching your carbs and your average blood sugar is still rising, that your body is on the downside of what your pancreas can make, and that is called pancreatic poop out, which is the other form of insulin resistance, meaning your body has been cranking out as much insulin as it can for years, but the beta cells which produce that insulin have an attrition rate, and they basically are going to die out over time, and you produce less insulin, so therefore your sugars rise constantly. So that's the natural history of adult onset diabetes, that every 4 years or so, because the pancreatic beta cells do die out and they don't make as much insulin, that we see a gradual increasing of this average blood sugar. This is a paradigm that's shifting all of the time, and what I mean by that is that several years ago, an average blood sugar of 6.3 or 6.0 was considered to be normal. Now the average blood sugar that's considered to be normal is 5.6 or less. And so now they've categorized, if you have between 5.7 and 5.9, your early prediabetes, between 5.9 and 6.2, you might be moderate. Between 6.2 and 6.3 would be heavy predisposition, and above 6.5 would be diabetes. That was maybe 2 years ago. Now it's kind of like that still exists, but then as we get older, and I don't know your age, that average blood sugar number may be normal, meaning that what you do is you take your age and divide it by 10, and that equals an average blood sugar that you should be. So if you're 80 years old, to have an average blood sugar of 8.0 is actually okay. To be 60 and have a blood sugar of 6.0 is actually okay. The theory behind that is that you don't want your blood sugar to go too low. Remember, this is an average blood sugar. It's a 6-week number. It's the amount of sugar molecules that will stick to your hemoglobin molecules, or your red blood cell, the molecule that carries oxygen in your blood. So it's an average over 6 weeks, and it takes that long for it to correct, meaning once you start a new therapy, you really shouldn't be checking that average blood sugar for 6 weeks, because the number will not be reflective of what the new therapy is. Or if, and in case I see this a lot, I start a new therapy and patients aren't very compliant with what they do, and they get I tell them to get their blood work done in 2 months, but they don't really stick with what we talked about, and the number really isn't very reflective. So if you happen to be one of those people, just don't get your lab checked and change your appointment and get with the program and get those numbers in line, so that the physician can actually interpret the number based on good information, because he's going to tell you, well, I don't know really what that means. You didn't really do what we were talking about, so therefore we have to recheck that number. So what I'm trying to drive at is that those numbers are going to, those paradigm numbers, or the shift in what we accept as normal, will constantly be changing. But as our population ages, the risk of untold effects from having low blood sugar can outweigh the benefit that you're going to get from having your blood sugar lower. Meaning 10 years ago, it was like, okay, we got to prevent all these late effects of diabetes. So we need your blood sugar at 5.6. We need it to be less than 6. We're trying to prevent all these late effects of diabetes. Well, in my experience, the late effects of diabetes tend to occur in isolated patients because of the way their body handles some of the sugars, or some of the things that they do. Meaning, you can have people that have really pretty decent sugars but will develop retinopathy, or they'll develop some other complications related to diabetes. And there's no reason why that happens to be, or at least we in medicine don't really understand why there are those outliers. So What are you going to gain when you're at age 65 to have your blood sugar at 5.6? Absolutely nothing, because at that point, when you're 30 and 40 years of age, you're going to try and make it to your age 65. So that's where the tight control is very, very important. Once you reach age 65, you would be nice to live to be 85, but the actuarial tables say that the average person lives 7 years after age 65, meaning 72 is the average life expectancy of an American. Now, it might be a little bit greater today, and the insurance companies haven't caught up, but that number hasn't changed, meaning that after age 72, average population doesn't make it. So if you look at all the payouts on all of the annuities, they basically they're scheduled at age 72. So what are you going to get in controlling that amount of blood sugar? Are you really going to get years added to your life? The answer is no. And now, if you're going off the deep end, then all bets are off, and I can't guarantee that you won't increase atherosclerosis, increase your risk of heart disease, meaning what I'm talking about is trying to get your blood sugar under 6 versus 6.5, or under 6.5 versus 7 when you're in that 65 to 70 group. So, Kathy, that 6.3 may actually be okay for you. Now, that being said, what can you do to try and stem the tide? They put you on metformin, which is actually a very good drug for weight control, and as long as your kidney function is good and your body can handle it. It's been a drug that's been out there for years, very well tolerated, except if you have, there are a few people that do have the gastrointestinal complaints, and they do have the problems with kidney function, even though that tends to be blown out of proportion a lot. But metformin works to reduce the effects of insulin spikes on your body. And that's where weight gain comes from. It comes from insulin in your body. So your doctor, not only, or your healthcare provider, doing your average blood sugar of 6.3, should also do a fasting insulin in the morning, and also a test called a glycomark. Glycomark is an average blood sugar of 2 weeks of duration. You have your average blood sugar, which is 6 weeks, but your glycomark is a 2-week average blood sugar, and that is a more reflective of what happens to you after you eat. So what I'm trying to say is, like, if you're fasting insulin, the normal fasting insulin may be up, they say between 0 to 10. Double-digit fasting insulin is very highly insulin resistant. It means your body's cranking out a ton of insulin to control your blood sugar, and that's a very dangerous situation for atherosclerosis, high blood pressure, and the untold effects of diabetes. So if you had an average blood sugar that was high, let's say 7.3, and your fasting insulin was low, that tells me that your body doesn't make a lot of insulin. And if your glycomark was elevated, meaning your average blood sugar after you eat, that tells me that your body is on the, what they call the pancreatic poop out side, that your body doesn't crank out a lot of insulin. And then your therapy would be tailored more towards insulin replacement than it would be towards giving you a lot of the oral medications, which actually need insulin to work. Some of the medications work more effectively when there's insulin on board, such as metformin, such as the secretagogues like Victoza and Bydureon, and some of the new ones like Trulicity. They have to have insulin in order to work. The drugs like Januvia and some of the other drugs actually need insulin to work. Now, some of the other drugs like glyburide and the sulfonylureas, which are old drugs, they whip the pancreas into making more insulin. So I don't like those drugs. They're not what, they increase pancreatic poop out. They will help control your blood sugar, but they will be working when you're not eating. And that's a very dangerous situation to be having insulin being pumped out when you're not eating. That stimulates appetite, that causes you to overeat. It can cause low blood sugar. You can actually have fainting spells. In fact, they were linked to heart disease because people were taking them at night and they were dropping their blood sugar during the night, which was causing norepinephrine release when you're asleep, which was raising your blood pressure and causing heart attacks. So I tend to stay away from the sulfonylureas. The insurance companies love them because they're cheap, but I don't like them because they're not really a good medicine, and they don't work in line with trying to reduce the insulin resistance and trying to reduce your dependence on that. And that's why I talk a lot about walking after you eat. Walking after you eat is probably the single most thing that anybody who's pre-diabetic or diabetic can do, because you're actually burning that sugar off in your muscles. You're not allowing it to be stored as fat. And I've talked about this a lot on the show, which is that insulin, this hormone that you make, is basically very anabolic, meaning it makes anything. It makes what you tell it to make. If you eat and sit, you're telling your body to make more fat. The more your fat stores grow, the more it acts like a sponge for insulin, and it forces your body to make more insulin, meaning being fat forces your body to make more insulin because the insulin you're making is ineffective. So it's a very vicious cycle of obesity, making more insulin, making more fat, making more obesity, making more fat. And the only way you turn that off is basically either, number one, to stop eating, obviously, but then to curtail the carbohydrates and curtail the other food that you're doing, but actually stem the watershed. The watershed is basically insulin, making fat, food, eating, but if you burn those calories, then your body starts making muscle, and it makes less fat because you're basically burning those calories, so you can't make more fat. A sugar molecule that is burned is not a sugar molecule that can be stored as fat. Just remember that. A sugar molecule burned is not a sugar molecule that can be stored as fat. And if you start to stem that tide, then you start to have weight loss and you start to reduce the amount of insulin. So basically, it's really a function of, and the type of carbohydrates you eat are very important. Carbohydrate load, glycemic index, we'll talk about that maybe a little bit after the break, because we're going to go to break a little bit. I hope that clears up or answers your question about insulin resistance and prediabetes. It's not the end of the world. If you're that way, you can correct it. You can make a difference. You can stem the tide. You can reduce your risk for heart disease, and you can get control of this. You can just have to walk after you eat. Anyway, we're going to be back in just a few minutes. All right, we got some paid advertisers, and thank you for tuning in.